specific conditions. The objectives of today's learning is to review a little bit about hypoglycemia, the biggest obstacle in the treatment of diabetic patients. And the second one, I would like to share with you in high-risk groups of hypoglycemia, how to minimize the risk. And finally, I would like to show you the data of second new generation of basal insulin analog to overcome the barrier in treatment with insulin in general, in type 2 diabetes, and in type 1 also. We can use basal insulin new generation. To begin with the first line here, I would like to talk a little bit about hypoglycemia, the core obstacle in treatment of diabetes. You see all that if our patient have a condition of hypoglycemia symptomatic with symptomatology of hyperglycemia, for example, polyuria, polydipsia, and loss of weight, and A1C, basal A1C is with at least 2% above target or a little bit high in the initial treatment. We would initial our treatment with metformin in combination with insulin by the guideline all over the world. And after that, if another situation is if our patient have a problem with also a with agent anti-diabetic by pills, if we have unsuccessful effect, we would think about the changing in intensification our treatment with the help of insulin. So to use the insulin is a big challenge because we know that all over the world we face the challenge of hypoglycemia in a rate very, very significant, more important in type 2 diabetes in comparison, in type 1 diabetes in comparison with type 2 diabetes. And hypoglycemia increase morbidity and increase healthcare resources. And hypoglycemia is also a limiting factor against achieving good glycemic control in our practice. We know that hypoglycemia can cause a big spend of resources, including healthcare system or individual, because they have to be hospitalized if they fall in a severe hypoglycemia. And so that the fear of hypoglycemia is the major barrier to insulin initiation, and it is the difficulty in optimal insulin titration. And if our patient fall into hypoglycemia, they will react with a attitude to take more foods without plan, and then that can cause later hypoglycemia, and that is related to later complications, and that can affect the adherence to diet therapy and compliance to taking medication. And about that can cause a clinical inertia. A clinical inertia not by patient but also by doctors. So we see that very, very late our patient can reach to a stage of insulin replacement, and that is a big barrier of hypoglycemia. So you see, in the practice, glycemic control is very challenging because of difficulty related to hypoglycemia in both type 1 and type 2 diabetes, more severe and more frequent in type 1 in comparison with type 2 diabetes. And for that, we would like to have a insulin or another agent that can make a good balance between the benefits of glycemic control and the risk and minimize the risk of hypoglycemia for our patients. So, in some special condition, I would like to show you how to minimize the risk of hypoglycemia because hypoglycemia can affect very severely in these groups. Look at this slide, you can see that there are two main groups that could be affected by severe hypoglycemia in the quality of life, in the morbidity and mortality. Is the group of patients with renal impairment and the group of older patients, even more than 75 years. That is very dangerous for them if they fall in hypoglycemia because they have impaired awareness of hypoglycemia, and very often the episode of hypoglycemia in elderly population are symptomatic, and that can increase the risk of severe hypoglycemia. And in the group of renal impairment, that can increase the risk more over of hypoglycemia, and that can limit the options of glucose lowering therapy. This we look all over the time for the solution, how to minimize the risk coming from insulin therapy in our diabetic patient. And over the time, we have a big evolution of basal insulin from first to second generation of basal insulin. You look after the NPH from the last century, we have the shoulder effect. The shoulder effect can cause the hypoglycemia from a distance from the males. After that, we can have first generation of basal insulin, compounding insulin detamine, and insulin glargine U100. These first generation of insulin already minimize the shoulder effect of NPH, but somewhere we have also a peak, a little bit peak at night with a detamine that can do less than 24 hours in the end of the day. But after that, are coming the new generation, the second generation of basal insulin analogs with glargine, the green one with glargine 300 and with insulin degrade. In comparison with glargine 100, we see that they are flatter, and the PK/PD of these two new analogs of basal insulin are very longer in comparison with glargine 100, more than 24 hours. That give with the hope that we can keep our patient safe during the night for limiting the hypoglycemia overnight. So we hope that with new generation of insulin, we can have a good balance between the benefits for seeking a good glycemic control and the minimizing the risk of hypoglycemia. Hypoglycemia can severely impact the lives of people with diabetes because our patient can have very difficulty in their life. They they could have more visit in emergency because of severe hypoglycemia, going to the hospital, and with the fear of hypoglycemia, they will discontinue their treatment. So the episode of hypoglycemia after that, like a consequence, will come and give them will cause them the complication later. And hypoglycemia, repetitive hypoglycemia can translate into hypoglycemia fear. So that can impact in the ability to drive of our patient, and that can cause the psychological problem like depression in our patient or anxiety. Nowadays, we have CGM like a way to follow our 24-hour glycemia. So we see that in many cases, the patient have repetitive hypoglycemia at night overnight, but they are asymptomatic, and that is popular in type 1 and type 2 diabetes. So, with this period of hypoglycemia causing later on hypoglycemia, it can cause the variability between during the day and between control, and the lead to in cardiovascular disease, and that can decrease the quality of life. Now we will look after the root of hypoglycemia. They are the risk of elderly population and the group of renal impairment. In this group, in elderly population, we see in type 2. We see that there are a factor that increase the risk of hypoglycemia. For example, the outer drug metabolism can cause by polypharmacology and the risk of drug-drug interaction that can cause more severe CKD with impaired before renal glucose release. And the problem with comorbidities that can cause the clinical picture more difficult to deal with. And the very important factor is impaired awareness of hypoglycemia in patients with repetitive hypo before. And in patients with impaired renal function, we see a increasing of renal function deterioration with the time. And here you can see that the hypoglycemia risk with or without diabetes and with or without chronic nephropathy is very high in the group, highest in the group with diabetes and with CKD in comparison with the group without. So, if we have some solution for these problems, we will look in second part of our presentation. We are talking about the evolution of basal insulin development from the first to second generation of basal insulin a little bit before. So new generation of basal insulin analogs are two preparation. We have glargine 300 and we have Degludec 100, and nowadays we have also Degludec 200. You see that the PK/PD of these two are even better than previous generation with glargine 100. So this new two preparation of degludec and glycogen 300 are better in the distribution in the blood during 24 hours, and that could minimize the risk of hypoglycemia in our patients. Furthermore, that is one convenience significant for our patient, that is we can inject this basal insulin in a fixed time or a little bit flexible time with 3-hour difference with the fixed dosing time and cannot change the effect. That means it is very convenient and practical for our patients. So now we will talk about the elderly population. What are the characteristics of this population? After the guideline, we would like to simplify the treatment regimen for elderly patients. We all know that in older patients, they have less perception of hypoglycemia in comparison with normal age person because they can't have a very good sensation feeling of the alarm sign of hypoglycemia. To avoid that or to recover of hypoglycemia when the blood sugar is too low. That is dangerous for them. So that in this population, the A1C is different in comparison with younger person. If for most adults with type 1 or type 2, we would like to have a A1C less than 7, and even less if a younger person. But in elderly person, we would like to avoid severe hypoglycemia and difficulty in awareness of hypo. Then we would like to reach a more flexible goal of A1C. And to minimize the risk of symptomatic hypoglycemia and acute and chronic complication, but not so strict in the aspect of hypo. So we can keep the glycemia of this population a little bit higher than normal. In individual life, we just avoid symptomatic hyperglycemia, and we would like to any hypoglycemia without concern about A1C anymore. This is the guideline of Association Diabetic over the world to simplify insulin regimen. And you will see here that there are many factors that can cause more severe hypoglycemia in this population. For example, the comorbidity may affect cell management abilities and capacity to avoid hypoglycemia. Moreover, they said that we should avoid hypoglycemia and symptomatic hypoglycemia at any price. What about the people with nephropathy and diabetes? You see that more than 20% of newly diagnosed type 2 diabetes have CKD, or they have decreasing renal function, either albuminuria, and with time, the prevalence of CKD increase with the duration of diabetes in all ages and all level of deterioration of renal function. In management of CKD with diabetes mellitus, we see that there is a standard a pyramid of guideline how to deal with CKD in case of diabetes mellitus. You see that nowadays we have a group of SGLT2 inhibitor that is very efficacious. But just in case the GFR are more than 30, even more than 45 for the safety. And KDIGO 2020 show us how to choose other one in the adjusting of treatment of hyperglycemia in the patient with diabetic and with CKD. About the insulin in this population. This table will show you all group of regular of rapid insulin for preprandial hyperglycemia and then all the range of basal insulin including NPH and first generation and second generation and mixed insulin premix insulin. They show us that we should minimize the dose of insulin in case the dose of insulin could change in case of renal failure. And also, the A1C goal in diabetes with CKD so is less strict than normal diabetic patient. That means we could change the goal of A1C very flexible depending of this group risk of hypoglycemia. We will do a assessment of the hypoglycemic risk of our patient to consider which one is the most appropriate for each patient. So now the data of this new generation of basal insulin analogs, if we have the data for that, yes, we have many data and I will show you some. Look at this, we have many group of studies that show us the safety data about the like senior, and then we have meta-analysis of RCT like the group of study of addition, and then we have real-world clinical setting in Deliver 3. All these studies show us that our new generation glargine 300 can reach similar or lower risk of documented symptomatic hypoglycemia in comparison with glargine 100 and reduce the risk of nocturnal confirmed hypoglycemia and documented symptomatic hypoglycemia. And in real world, they show us that new analog insulin like glargine 300 can reach a similar glycemic control and significantly lower risk of hypoglycemia in comparison with the cases switching to other basal insulins. Look more closely in the detail. Firstly, I will show you the data from senior study. Here, you could see in elderly population, we can reach a comparable glycemic control with glargine 300 in comparison with glargine 100 in two subgroups more than 65 and more than 75 years old. And what about the risk of hypoglycemia in this group? You see that comparison glycemic control, the same, but here you can see that they reach the lower rates of documented symptomatic hypoglycemia with glargine 300 in comparison with glargine 100. The favor is for glargine 300 for the criteria of hypoglycemia at any time of the day, and especially in nocturnal hypoglycemia that can be very dangerous for our patients. In summary, glargine 300 had a good efficacy and safety profile in older patients more than 65 years of old with type 2 diabetes. It can demonstrate comparable reduction in A1C in comparison with glargine 100, but with less risk of hypoglycemia. And the same thing is observed in the population of participants more than 75 years old. And next are the data from the serial studies edition. In the patient, we see that glargine 300 in comparison with glargine 100 can reach the same A1C at the end of the study. But how about the risk of hypoglycemia at month 6? In all the group of study, we see that lower confirmed hypoglycemia or severe hypoglycemia with glargine 300. You can see here, here, and here. So the same thing we could observe at month 12. Less hypoglycemia in favor of glargine 300 in comparison with glargine 100. In summary, this post-hoc analysis in adults aged more than 65 years old confirm the comparable glycemic control but with less hypoglycemia risk with glargine 300 versus glargine 100. The study of DELIVER-3 is a real-world study, and in this study also show a similar glycemic control but with less hypoglycemia after switching to glargine 300 versus other basal insulin. Very significant with the result of less than 48% less hypo. And the BRIGHT study is a study comparison between glargine 300 and degludec. We see in older adult patient with type 2, in population more than 70 years, even more A1C is reached with glargine 300. And with similar hypoglycemia risk for glargine 300 and degludec in both groups, you see here, they both are the new generation of basal insulin analogs. And what about patients with CKD and diabetes? You see that CKD occur in 20 to 40% of people with diabetes. And CKD is an independent risk factor for CV disease. And well-tolerated and effective treatment option would help us to allow people with type 2 diabetes and CKD to achieve glycemic control but minimizing the risk of hypoglycemia. Here you can see that the study comparing glargine 300 and glargine 100 in type 2 diabetes regardless of renal function that can reach the same glycemic control here between two insulin. But what about the risk of hypoglycemia? Here you see that we can have a lower risk of nocturnal hypoglycemia with glargine 300. It is very consistent, independent of the of GFR of our patient of renal function. Very consistent. All criteria of hypoglycemia is less with glargine 300. And the BRIGHT study also shows us that we can reach a greater A1C seen in use with glargine 300 versus degludec here in population with moderate and severe renal impairment, more efficacious with glargine 300. And what about the incidence of anytime confirmed hypoglycemia between glargine 300 and degludec 100 between different groups of renal impairment? We can see that the favor in many groups are in comparison is the favor for glargine 300. Especially in the group with the eGFR more than 90, we see that the glargine 300 is superior in comparison with insulin degludec. So, for the conclusion, we can say that hypoglycemia is the most challenging obstacle limiting the intensification possibility of treatment of patients with diabetes mellitus, and we can choose the balance between the benefits and the risk of hypoglycemia risk to choose the right insulin. And in the high risk group population, like the elderly population and the group with CKD, we should consider this insulin therapy with lowest risk of hypoglycemia for them. And between the choices, we have insulin glargine or 300 is a new generation, second generation of basal insulin analog with proof in data for safety in the high risk hypoglycemia group. With this way of treatment, we can overcome the obstacle, the challenging like hypoglycemia, variability of glycemia, and the decreasing of quality of life of our patient. And now we can give our patient a better life. So, with that, we, doctor and patient, could together overcome the obstacle. And that is all of my presentation. And I would like to thank you for your attention.